You're welcome back. This is Newsfile. It's your most authoritative news analysis platform, and here we are trying to assess Ghana's progress so far. We want to check if the evidence backs the praise that Ghana's team is receiving, and then many of you have even brought in questions. You're asking, should you be expecting some lockdown, if not general, in specific areas where it appears that there's a disproportionate distribution of the cases, and so on. So we'll get to all of that. And then there have been questions raised about some challenges. There are even frontline workers who have complained about PPEs. How far are we doing with all of that? Yes, so, Doc, some people want to know, for example, and I asked that question to Dr. Silverke, when can we look to real-time results so that we don't have to wait 2 weeks and we don't have to have a COVID situation where he's waited almost a month now?
Yeah, thank you very much. For the greatest backlog challenge we had was more with KCCR, because they don't have as many PCR machines as Noguchi. And if Dr. Silverke said they are going to be ready by early next week, then that will mean that by that time we should be able to do a catch-up. But there's been a lot of ramp-up in Accra, and be able to look at that, so we can look at it. But I just want to also...
You said that about KCCR. How about Noguchi?
Yes, Noguchi had a smaller number of backlog compared to KCCR. And looking at the capacity of Noguchi, if KCCR can catch up by early next week, Noguchi should be able to do the same.
In fact, one KCCR had about 13,000 backlog. Noguchi had about 5,000. So clearly, Noguchi's capacity is way bigger. And once they've been able to come down on their numbers to 5,000, and looking at the rates at which they are testing, clearly Noguchi should be able to do that quickly. But that will also depend on the kind of contact tracing we are doing and the numbers of people who are being roped in. Because as the numbers surge up, we are now around 2,074 officially. But we know that in the next couple of week or two, we may be doubling, we may be getting like, say, a 30 to 50% rise or something. These are our projections. And once that goes up, that's new numbers. 20 or 30 or 40, maximum 50% of the current figure, we need to do contact tracing for them as well. So that what it means is that a lot more people might also be brought on. So yes, we are aiming to clear the backup, but we also need to get people to understand that the dynamics are not that simple, especially now that we are doing the enhanced contact tracing and testing.
And is it the pulse sampling that we are still using? Particularly, is that only for Noguchi, or everybody else is doing that, all the testing centers?
Well, I know that KCC also do pulse testing, and probably that's one area that, I mean, I'm not a virologist, but I'm sure these are proven tests that I also know that many Western countries are doing the same. In a country where you have a low prevalence like that, what it means is that with about 1.8%, if you did about 100 tests, you get only about 2 positives.
At the Ghana Health Service, you have the Ethical Review Committee. They would have to approve that this pulse sampling has to be done. Have they given that approval?
The universities have their own Ethical Review Committee. Noguchi has his own Noguchi, so they don't rely on our Ethical Review Committee. But these are methodologies that have been there for a long time. And in science, you won't have all kinds of debate that will go on every method. And someone may believe in another method, someone has big issues with that. And so it's something that will probably...
But you may need to be sure of approvals, maybe the CDC or WHO would have had to approve them.
We don't need CDC, we don't need WHO. We have our systems here to look at, and Noguchi is a highly respected lab in the world, and we believe that whatever they do is above board.
Okay.
But I just wanted to make some comments on what Mr. Sedu from London, the pharmacist.
Yes.
You see, some of these figures, if you look at them, it depends on exactly what you're doing. The first 39 days we're talking about, we're just doing routine surveillance. As soon as you start going out to look for who has it, the numbers are going to change. And so if you start ramping them up in those positive, it becomes a bit and some of the deaths, it's not as if those were deaths in the last 2 days prior to that. It depends on when the death is reported. Some of them were died on arrival, samples were taken, so the results comes in a week's time. And then, of course, we are being transparent, so we add it to the list. If you remember the last time I said, we are evaluating the figures and confirming that, and once we confirm, we publish them. So, I mean, 17, if it's in your family, is a lot. But looking at the number we are dealing with, we still have a relatively low mortality rate. So those increases in positive, it's all about how you get a full picture. In surveillance, it's not just about the numbers. You have to look at the full picture. If you say, for example, Eastern region is becoming a hotbed, Eastern region may just have one large camp where you have so many people positive. That doesn't pose a threat to the region. So you may, even in our classification, we classify Central region at a higher risk than Eastern region because the Eastern region ones are circumscribed and you can really deal with them. But when you have sporadic ones spreading everywhere, one here, one there, then you have that's when you. So the classification is not so much only about the numbers, where they are and how they are acquired and how you can be contained.
Right. So what are some of the challenges that you have faced over the period? We have heard from some of the people on the front line. You are the one sort of coordinating everything that has to be done. What are some of the challenges you face? And we want to know them so that those that concern us, we can assist you.
Yeah, but I think PPE has always been a big issue. PPE is, they are more like supplies that you may have today, you will not have tomorrow, because they have to be replenished all the time. And so where there are a few supply chain issues, you may have a distribution challenge. That's one. Initially, we had a major distribution production challenge. Even when we started, even if you have money, you can't find to buy. So, but now that with the local productions, a large number has been done and currently being pushed. And see, when you're dealing with medical things, it is not just produce and share. You produce, you test, you do quality control, and then because what we don't want, I'm sure you've heard that is it Germany or so, or one of those countries where they have rejected their PPEs, that they are not safe. All those things have to be checked to ensure that whatever reach the health worker is of good standard, that's protective, and so that doesn't give you you think you are protected when you're actually having masks that has holes in them. So those are a few supply chain issues, but now that the production is ongoing, we should be able to, they are being resolved.
What else?
Well, the most important one is the behavior of our people. And one is the fact that people are not adhering to the social distancing, hand washing, etc. That creates a big challenge for us. That would mean that all your effort to contain it's been eroded because people will continue to spread because they are not abiding by those things. Sometimes through the way information is handled, one of our greatest things that we are doing is isolation. If I'm not sick and I'm isolated in some place, it is not a very pleasant experience that you are mild, you don't have any complaint, but because of the cases you are managing, you are isolated from your family, etc. And so when media goes there and raise issues that affect people's ability to now accept to go there, it affects our efforts significantly. And I think that's something that has to be looked at, that you go and raise all kinds of issues which are normal, that if I'm put somewhere, I'll not be happy, and you come and blow it as if you don't have this mortar this morning, and becomes a big issue. What you are saying is that those who are now ready to come should refuse to come, and then that creates a big problem for all of us. And I think those are some of the things that we really need to look at.
Okay. So, Dr. Yankson, there are those who suggest, for example, that one of the challenges should be the inability to get real-time, test results. And it is not exactly about the testing centers, and that the officers who are supposed to do the contact tracing and bring these results, or government, so to speak, is part of managing that timing. What do you know about that?
Okay, let me just add a quick one to what Dr. Abuaji said. When it comes to the attitudinal bits, we should look at what we are doing as a state. I know the risk communication and social mobilization team within the structure headed by Dr. Abuaji da Costa. I've been part of the work, and I know they've done a lot of work, and they are still doing a lot. But then, if we look at the attitude of the Ghanaian generally, not that Ghanaians are difficult, but our brothers and sisters who don't seem to be adhering to some of these rules, then what it tells us is that we still need to do a lot more education, a lot more of the social mobilization and communication to ensure that the problems that Dr. Abuaji raised vis-a-vis the communication and how things are being done in some of the centers are actually corrected. And then even in spite of whatever reports that may come from some of these centers, we need to look at it in two aspects. One, if there are genuine issues that the media is raising, for which reason government or the system has to address, definitely we need to address it, because if that is left unchecked, it also becomes a disincentive to the fight that we are all waging. And then two, for the ordinary man who may be fed with this information, that person should also be made to understand that your own personal circumstances might be different from somebody else. And that if you are positive, for example, or you know you are high risk, but you are refusing to be moved to a particular point where you can get proper care, it could inure negatively to you yourself as a person, your immediate family, and the community you find yourself in. We need to sort that.
Yeah, the question I was asking was about this real-time testing thing results. The suggestion is that government's response, team is sort of managing the timing. There are those who have also raised suggestions within your fraternity that even the mortality data is also being managed.
Okay, what we are saying is this. It is not just about the communication, especially when we look at the hospital setup, that today our numbers have gone up by, say, 100 or 50 cases. But at the hospital level, for example, what we want is real-time results, i.e., the clinician who has identified a suspected case and has requested that samples be taken and is holding this suspected case in the health facility needs to get the results quickly, because decisions will have to be made based on that results. So if you delay for a couple of days to a week plus, you are hampering the work of the practitioner. Beyond that, you also put the health personnel at risk, because here is a patient who everybody suspects, at least per the protocols, to be potentially a candidate that can be described as a positive case, for which reason we've done the test. Now, once you know that, it means you need to take extra preventive measures to ensure that you don't contaminate your health professionals. And then, if the patient is such that the patient is one that was on the ward before the decision to screen was made, you also don't contaminate other patients and relatives, visitors who come around. So for us, the real-time results is not even just about the numbers, as in the publishing of the numbers that we have 100 and what have you. For us, it is about receiving the test results quickly to enable us to take decisions. Of course, in the bigger picture, Ghanaians want to know the numbers. So if they are being updated on a regular basis, they then have a lot more confidence, because in this exercise, confidence is one thing. If you don't let your people come along with you because they have lost confidence in you, you might not win the fight.
Okay. Let me pick Kwame Sapong-Asiedu's mind on this. The suggestions that the government's response team is directly influencing, the timing of case disclosures. how can they give a response that will take away that kind of, claim, if it is not true? That mortality data, it's being managed. What can they do? For example, should they be giving us the dates of the deaths? Dr. Boaji said the deaths have just not occurred, don't just occur. Should they be giving us the dates of the occurrence of the deaths, for example, so that there will be sufficient, disclosure on these matters, transparency?
I wouldn't say so. The point is that there are ethical issues when it comes to managing what's called patient identifiable data. So, for example, you wouldn't want to be putting out time of death because they are people's loved ones and they are close to them. But what you want to know is if whatever you do with epidemiological data, there would be a lag time. We all know that. There would be a lag time between the time the incident, even like if a sample is collected, there's a lag time between the sample being collected and getting to the lab. And like Dr. Swanika explained, depending on the quality of the sample, there would be a lag time between sample preparation testing. There would also be a lag time between sample testing results and actually certification of the results, because there are quality control and quality assurance measures that go on with these things. And then there would be a lag time between the certification of the results, communication of the results, and official release. From where I sit, all these lag times have to be lumped together, and we need to know. Why do I say so? Because with epidemiology, you plot epidemiological curves. It's from the curves that you can determine, is the R number changing? Is it going up? Is it coming down? Is the curve flattening? Is the doubling time changing? Is it coming down? Those are the things that will determine the measures, whether we need to get harsher with our measures and all those things. So it is not about saying that specifically give us, because it's virtually impossible to give real-time data. But let us know that the data that's being reported is in 24-hour lag delay, 48-hour lag delay. So if someone like me picks the data from the Ghana Health Service, like Dr. Abaji said in response to what I said earlier, that, they went into enhanced testing. If I get the data from Ghana Health Service and I'm using it to do projections and modeling, the data comes with a day, and that's what I'm going to do. However, if I know that there's a week or 7 days lag time, I would factor that in. And I'll give you a typical example. When we were doing the crude calculations for Ghana's R/U currently, we used a 7-day lag time and a 5-day lag time simply because we had heard on the grapevine, and like even some of the calls said, that it was taking up to 7 days. Some people would say up to 12 days to get all this. And we came up with 2 different numbers. And so that is instructive, because if you are then going to advise anyone or inform anyone or have conversations with the media like I'm having with you now, I am disadvantaged because I cannot actually critique or praise the government's position and their trajectory properly. And these are the reasons why. So when I hear people ask, why do you want the data quickly? What do you want to use it for? I really see a lack of understanding of the different roles that different people play. The government has a role. The likes of Dr. Abaji have a role in managing it. Civil society has a role in understanding what's going on, because we live in a world where, even in the UK, I'll give you an example when it came to the deaths. Initially, all the reports that were coming up were the deaths that were happening in hospitals. And then the press and civil society organizations started kicking a fuss because that didn't show the true picture. There were deaths happening in nursing homes and at home and in other areas. So now the data that comes is the composite data. Why did that happen? It happened because people went onto the ONS website and started scrutinizing the official government data, knowing the lag times and all that. So if we don't have these things and we just accept them and accept the government position or the Ghana Health Service position as the absolute gospel, it makes our fight also difficult, because the government and the Ghana Health Service need the input of all stakeholders to be able to realize if what they are doing is robust enough. And like I said when I started, I don't criticize, or no one criticizes because government or Dr. Abaji and co are not doing their best. It is, can they do better? What can we do to stretch the yardstick so that ultimately the Ghanaian and the general public and our economy benefits?
What one aspect do you think they can do better in?
Well, the first thing is what they've said about clearing the backlog. Because if they clear the backlog and the results are coming in real time, which still would be delayed because of the sampling and all that, and it gets to them, update the website, say every 6 hours, every 24 hours. If you look at Worldometer and all that, that is what's happening. Update it so that people, so that then even information that people like I put out is more informed. Because you then know that I'm getting this data every 6 hours. I'm getting it every 24 hours. And I think if the government and the Ghana Health Service did that, I know it's difficult, but if they did that, it would enhance the debate and it would even enhance the education of the Ghanaian so that they comply with some of these social distancing measures.
Okay. Now, Dr. Savakin, when you listen to, or you having become aware of the disproportionate distribution of the cases, are you in any way contemplating, like some of our viewers and listeners are, that the universal lifting of the lockdown is not the best, and that there's a possibility of some sort of lockdown to help you do your work better?
Indeed. Just before I go to the substantive issue, we also need to recognize that even when we receive the samples, we prioritize them. So if these are suspected cases, so people are in the hospital, then definitely we stop everything we are doing, and because we know the clinicians or the attending physicians would need the results to enable them carry on with any sort of management. Okay. And then I think you also made a point about getting clearance, ethical review to enable us do the pooling. We don't need ethical clearance to enable us to do pooling, because pooling is an established protocol. It was established by one Danford sometime in 1943. And for our work on coronaviruses, we have been doing pooling all the time. Okay. But the point I also want to make is that you don't just get up and start pooling. The first thing you do as an expert virologist is to establish something known as the limit of detection of your assay. So once you do that, then you would know that my assay is such that it is able to detect one copy of my virus. So if I have just a copy of the virus in 1 microliter in a tube, my assay is so sensitive that it is able to detect it. So you can also do sensitivity and specificity. But then the critical thing you do is to do the limit of detection of yours. So there's really no qualms about us doing pooling. But of course, like Dr. Abaji said, a point will come when pooling may not be very useful. Okay. Because if you realize that your positive rates are going up, then it means that for every sample you pool, and again, I also need to say that you don't just get up and say, I'm doing pools of 5 or pools of 10. You need to do your own background checks and decide on that. But like I was saying, if you get high positivity rates, then it will mean that almost every sample you pull or samples you pull, chances are that every single one of them may turn out to be positive. Then you have to go back, and we, in the field of virology, we call it resolving the pool or dissolving the pool. So there's a time you do pooling and there's a time you do not do pooling. But the critical thing is about the fact that you have to determine the limit of detection. And so this, you can do serial dilution, downstream dilutions to enable you determine the limit of detection. But it has actually generated a lot of interest. Now people know about pooling and all and all that.
Okay. So, and that's that small bit of the question I asked you, depending on the distribution of the cases in the various areas, are you contemplating, is this something you think about, that there's a possibility that there will be some lock down in some places in a way also to assist you to be effective?
I think so, because there should always be a story behind every single one of these positive or confirmed cases we are seeing displayed on the website. So, for example, Central Region, I don't know whether these are contact tracing. I don't know whether these are suspected cases. I don't know whether these are imported cases. So obviously we need some disaggregation of the data on the website. And I think the president actually said it, that, look, there may be a point in time where we may be doing some targeted lockdowns. And he even used the word curfews. Yes. So that if we realize that people in some communities are becoming stubborn, then they will impose curfews on them. And I think we may already be looking into that bit, because if I look at I look at Upper East region, we remember this young boy, I think somewhere in Wale Wale, who died. He passed on, and even the family members were contemplating. They actually insisted that he had asthma, so he had an asthmatic attack. But then a week after his death, one of the family members also tested positive. We also remember the pregnant woman who claimed that she did not travel. I think she said she went to Takwa, yes, and then she was tested and she became positive. If you go to other countries, such as Germany, look, they have history behind every single sample. I know that at least for the 13th case recorded in Germany, the Munich cluster, it was just because somebody passed on salt from a table in a restaurant. So if we get to know some histories, this is not about disclosing the identities of our patients. Right. But if we get to have a bit of histories, Western region, I don't know where these numbers are coming from. I mean, Ashanti, I also don't know where these numbers. So we may also want to look at some disaggregation and actually focus on specific hotspots. Okay. And I love the sports map being displayed on the website. Now we can actually see where the numbers are brewing. Now, can we go in there and do some targeted, very, very targeted, if we've got to suppress them, so declare a total lockdown in such communities, and especially if they are also not adhering to laid down mitigation strategies? Do we even want to impose some curfews on them? I think we may want to start restructuring ourselves. We may want to start revising our notes. So, because look, we need to be ahead of this virus. Right. You do not want this virus to be ahead of you. Especially for me, I call it a smart virus, because look, you may appear healthy, you may be hale and hearty, but you may actually be incubating, and you may also be shedding the virus. So I think that if we are able to see some disaggregation, and of course, it will also help those who are into modeling. I am not I don't model, but I'm sure that once we disaggregate these numbers, we will be able to calculate the reproduction number. We may be able to say that, look, in Ghana, I mean, we had to collect data from other sources because we wanted to also look at the reproduction number. And we had to pick information from other sources. But if we have it displayed on our website, or we have it made available, I'm positive that we'll be able to get along and get around with all the things we are all yearning to find. Right. I know that already the Ghana Academy of Arts and Sciences, look, they have put together excellent experts. And I'm looking forward to them coming up with some of the exciting things, the modelings, the predictions we are all interested in seeing. We know that once we see these predictions, these numbers displayed, look, it will allay some level over optimism, because initially some people even thought that, look, as for Africa, because of sunlight and all those things, the virus will even not be able to survive in our environment. So for those who are super optimistic, it may bring them down. And of course, for people who are also very anxious, maybe that level or the level of anxiety will be reduced. So I am always talking about us disaggregating the data, and I'm positive the Ghana Health Service is already working towards or in that direction.
Okay. As I hear from Dr. Boaji, they've done that already. I'll let him confirm that quickly, but Dr. Jansen, should people have an expectation that sometime soon the Ghana Medical Association will issue another, statement asking for targeted lockdown in any place, and which are some of these places that you may be looking at?
Well, the association, as it stands now, keeps looking at the bigger picture to see what the next step should look like. So for us, we haven't taken anything off the table, generally speaking. And like Ken said, this bit about targeted communities is one of the fights we can do. Korea did something of that nature, other countries have done it, and it's yielded results. Especially when you look at the situation we find ourselves in, where some people seem to have forgotten about all the preventive bits following the lifting of the lockdown. So we think that it is fair that all these measures will not be taken off the table. We should look at it, and holistically, wherever we think that it has to be done, it has to be done, and done well. It shouldn't be lip service. And people should understand that as and when, God forbid, we should get into those scenarios where whole communities will be locked up for testing, screening, or whatever that has to be done, and isolating people and treating them properly to ensure that at least we limit spread. People should begin to understand and cooperate. But if they don't want things of that nature, then obviously we need to ensure that all the preventive measures that we are preaching about, they obey them, because that is the only way out for all of us. People are just not responding to some of the calls we are making. And that makes the situation such that it forms the basis for the very things that people are not happy about to come back into the system. Okay. Of course, we are happy that the president has made it clear that he's not averse to going back to some of these measures. And we think that it's about time that we strengthen some of the measures. The enforcement in his
last speech, though, he gave an indication that the expectation when he speaks to us the next time will be to begin to lay down or out measures towards easing, the measures.
Of course, that may be right, but if the reverse is happening, and I don't think that the president will also be justified in just lifting the measures when clearly the reverse,
like he has always said, he will speak to the science. Okay, so Dr. Boaji, before we take a break and then come to finish up, you were confirming that you have already done the disaggregation, because what is being said is that that is what we need to survive the disease.
Yeah, thank you very much. I think there's so much you can put out there. This, you are dealing with a human beings. I mean, we even put a map there, and somebody's able to zoom to see which house the case is coming from.
Okay.
It becomes a stigma issue.
Okay.
So we also have to know how to measure. I'm sure the Sasevakan is talking about Bolga. He knows about this. Excuse me, at me that she has seen it somewhere. These reports are there. Regions give situation reports every day. But that is not for the general public. Giving us details about who is affected and where the person came from Takwa or Boase. I mean, one of the issues...
Is that the mapping the University of Ghana did?
Yes. I mean, they take the data from us. And we are the ones working with Ghana Association of Arts and Science, we had a webinar with Thursday to give them all the information they need, age, aggregation, all these things are there. But I don't see any country putting all that information on their website. If you are a research institution and you want the information, you know how to get the information. But we also need to, these are ethical issues about people. It's very easy to identify that put a case in Upper West on the field, on the report, and it's very easy for everybody to know it has to be this man. So there are ways that we manage the information. But all this information is there. If I show you what I have here, in terms of the differences that came last week, we know from every district what was the rate of change. And all this information is available for those who need it. But there are ways of some of this message information has to be appropriately managed. And if any research, reputable research information wants information, they know how to request for information so that we don't just spread too much on this thing. When the previous website, there was a lot of information, nobody was reading. Everybody was interested in the first screen, you know, and so they ask you a question that's already in the site. So those are some of the challenges.
No, but Tabaji, you see, I agree with you by and large, but I think that we should also try and meet the expectations of some segments of the society that are interested in some of these things.
But,
and like, you know, like Silvakin said, we were all looking at least for those of us in terms of caregivers or the health professionals. We were very excited when we all saw the hotspots and what have you.
Yes.
Because in even interacting with patients, it also informs you, the practitioner, to look out for certain things.
Yes.
That is why we take a lot of social, you know, history and what have you. So I think that we should try as much as possible to blend the two. Yes, we cannot put everything out there. That I agree. But where we think we can do the disaggregation, the mapping, the hotspots, all those bits, clearly we should be able to do that at least to ensure that the others out there who are also professionals but are into research and out of their, you know, projections and what have you, they can draw some safe conclusions that will help all of us. We think we need to do out there. But for me, the biggest challenge I think we should be confronting now as a country is the behavior of our people. We need a behavioral change. People think that where we are, probably we are safe. We are not. Let's be honest.
No, we're not.
And it's up to government and the ministry and all related agencies to ensure that we do that. And one of the best...
But just to let you know that we share this information a lot with associations.
No, I agree. I get reports. What I'm trying to say is that we should still listen to those.
As we take the break, there's this concern I think you should address before we do so about patients at the Pentecost Center complaining of poor feeding, shortage of water, among other things.
Yes, thank you very much. That was the day before, when, in fact, the whole of yesterday, I was there from about lunchtime to about 6 p.m. just to see what is going on, and those things have been resolved. Initially, there was some delay in I think they had an issue with the water supply, and that they have quickly had to, because the same place supplying Kolebu and the place, and there was some diversion. And so all those things have been resolved. We've talked to them, we've had this thing, their meals have improved, etc. You see, what happens is that we move people from a 4-star hotel into that place. Definitely, there's going to be a big difference in their expectations. But we are working on it, and even today, I went there, the environment is so now they are doing some more like a parade for somebody who has tested negative will be exiting the distance. So the mood is quite high, and I think we need to resolve a lot of the
among their complaints. They were saying that they were being served with is it Eba Gare Fufu late in the night.
Yeah, there was a day there's a delay. They ate, their supper was about 7 p.m. Yesterday by 6 p.m. supper was ready. It was not just one, it was jollof rice with yam and some fried rice. So they are giving them variety with fruits and vegetables, etc. That is being
and we're also saying they don't have doctors who routinely will check on them, you know, among other things. And that was...
if it was allowed, I would have showed the pictures of... We have 40 health workers sleeping there with a tent where they see them, those who have issues are seen, and they are there 24/7. Taking care of them. I'm sure GMA will attest to that.
It's good you brought up some of these things. The good thing is that center has become a very integral and important part of our case management now. And for us, the key thing is that government, as the lead person in all this, by way of provision of resources, should ensure that whatever the problems are, within the shortest possible time, they are all resolved. And then moving forward, we put in proper structures. And whatever we replicate there, we do it such that as and when we need to move elsewhere, we have.
But if they have to complain, it shouldn't be about toilet rolls.
Yeah, that's what I'm saying. That's exactly what I'm saying. That we need to ensure that we have clear-cut SOPs.
That center is holding about how many people?
Currently, as I said, they have about 400, but I'm sure at the time I left them today more.
And it has a capacity of about thousands.
700 actually.
Okay.
We have about 110 people who are staff, security, health
they
workers.
take a bit of that.
Yeah, that takes a bit of it. But now, I think there was a little delay. All this, now we're going to give everybody a package. See, you get to know some of these things that people will come there and not have sponge and all those things. So you learn.
Okay.
And then we quickly have responded to make
all right,
sure
thank you very much. We take a break and we resume for the very final installment to ask questions about the GMA, for example. We have heard them suggest that we don't have personnel for the 94 hospitals that the president is promising for this year. Have hospital facilities that were built by the Mahama administration been abandoned, as has been suggested. However, the testimony clearly is that, but for some of those infrastructure developments that were embarked upon, we would have been in very difficult times trying to get isolation centers and treatment centers managing the disease. We'll be right back.